sir. Good evening, everybody. I welcome all of you to 15th Clinic Summit of Advanced Gastro Summit. And I thank Gujarat State Chapter of ASI, Gujarat State Surgeon Association, Association of Physicians of Gujarat and Ahmedabad, and Family Physician Association who have contributed to make this event successful. Today we'll be discussing on inflammatory bowel disease and how to differentiate among its differential diagnosis. Today we have a very prominent speaker, Dr. Vineet Ahuja. Before that, I would like to invite and introduce Dr. Joy Abraham, who will be moderating our today's session. He's a senior GI surgeon from Ahmedabad and good experience in various surgeries pertaining to IBD. He has Excel Hospital in Ahmedabad. And Dr. Joy, please introduce today's faculty, today's other two faculties, chairpersons, and Sandeep, please introduce Dr. Vineet Ahuja.
Thank you, Dr. Yogesh, for the kind introduction. With a lot of unmitigated pleasure, I take this opportunity to welcome Dr. Ram and Dr. Sandeep. Dr. Sandeep Shah and Dr. Ram Parihar, as Dr. Yogesh told, are consulting gastroenterologists with the GastroPlus team. And welcome all of you to this epoch event of Advanced Gastro Summit 2020, which is extended on to 21. So today's topic would be discussed by Dr. Vineet Ahuja. Dr. Sandeep, please, you can take over from you.
Yeah, thank you, Dr. Jai. Good evening, everyone. Actually, we are privileged to have Dr. Vineet Ahuja today with us. And actually, he's a professor of gastroenterology at All India Institute of Medical Sciences, New Delhi. He's an eminent international faculty and have done a tremendous work on an inflammatory bowel disease. He's an author of various landmark papers and also contributed to forming an Indian guidelines on inflammatory bowel disease. So it's an absolute honor to invite Dr. Vineet Ahuja, sir, for today's talk. Over to you, sir.
Thank you very much, Sandeep, and thank you, Yogesh, for the invitation. And I must say, your series seems to be doing pretty well. And I have attended your conference at Ahmedabad. Yes. That was an absolute pleasure. So I hope that very soon, another 6 months, I'll have the pleasure, or maybe next year, we'll have the pleasure of having a live conference once again. Yes. So I'll share my slides. I'll be talking about today that we will be discussing about a 25-year-old lady who comes with bleeding PR and subsequently is supposed to have a diagnosis of IBD. So how do we go around? What is the approach in such a case? So first thing is obviously to establish the diagnosis. Although as the title suggests that here we are dealing with a case of inflammatory bowel disease, yet at the same time, when it comes to something like ulcerative colitis, I would like to see that what kind of possibilities come to our mind, then how do we decide that what should be the first approach in terms of managing and subsequently the second and third line therapies. So this lady comes with diarrhea for 3 months, blood and stools and rectal symptoms in the form of tenesmus. In such a case, the first thing we should come to our mind is, okay, is it acute diarrhea or chronic diarrhea? Is it small bowel diarrhea or large bowel diarrhea? I'm not going to go in too much details about small bowel diarrhea or large bowel diarrhea because that's a topic of discussion next week by Dr. Govind Makharia. Nevertheless, first thing should be very clear. Inflammatory bowel disease is a chronic illness. It's a lifelong, remitting, relapsing illness. So chronicity is very important. So you need to differentiate whether it is acute or chronic. Acute, by definition, when we talk about acute diarrhea, by definition, it is less than 2 weeks. Chronic, by definition, is more than 4 weeks. Anything in between is persistent. Second thing is whether the diarrhea is organic or functional. These are 2 or 3 questions which are important and which help you in pinpointing the diagnosis. So after you have decided it is acute or chronic diarrhea, second is it is organic diarrhea or functional diarrhea. We don't need to go through the whole table. Simply if I tell you the gist of the table, if the patient has nocturnal diarrhea, if the patient has blood and stools, if the patient has alarm features like weight loss or anemia, then you're dealing with organic diarrhea. However, if the patient does not have nocturnal diarrhea, does not have blood in stools, does not have alarm features, then it's a possibility that the patient has functional diarrhea. Third question, the diarrhea is small bowel in origin or large bowel in origin. Again, let's not go through the table. Main points are large bowel diarrhea would always be small in volume. The reason being that if rectum is inflamed or if rectum is involved, then as a result, what happens is it becomes irritable. The reservoir function of the rectum is lost. So any amount of fecal effluent which reaches the rectum leads to a sense of urgency. There may be blood and stools in patients with large bowel diarrhea. Whereas in small bowel diarrhea, you will have symptoms, signs of malabsorption or signs of malabsorption, like steatorrhea or excessive flatulence or pedal edema because of protein malabsorption. Pain would be on the flanks in cases of large bowel diarrhea, would be periumbilical in small bowel diarrhea. So overall, there are three questions. The three questions are acute or chronic diarrhea. Chronic is more than 4 weeks. Second, organic or functional diarrhea. Organic is nocturnal stools, weight loss present, or maybe fever present, or blood and stools present. Third is small bowel diarrhea or large bowel diarrhea. Small bowel diarrhea would be large in volume. Large bowel diarrhea would be small in volume. There would be rectal symptoms in large bowel diarrhea like frequency, urgency, tenesmus. There would be blood and stools in large bowel diarrhea. If there is pain on the flanks, that would be more suggestive of large bowel diarrhea. So once I made this localization, then the next thing is obviously it helps you in determining the causes. For large bowel diarrhea, the major causes can be divided into functional or organic. The commonest cause of large bowel diarrhea, I would say, is irritable bowel syndrome, or that's a functional cause, or that's a functional cause of large bowel diarrhea. Whereas when we talk about organic causes of large bowel diarrhea, then the commonest cause would be inflammatory bowel disease. That would be ulcerative colitis or Crohn's disease. You would like to think about tuberculosis. You would like to think of colorectal cancer. If blood is not present, then you can think of drugs causing diarrhea or microscopic colitis. So, when we talk about inflammatory bowel disease, we have to remember that these are immune mediated chronic inflammatory conditions of the intestine. It consists of ulcerative colitis and Crohn's disease. There's another entity known as IBD-U, or where you're not able to differentiate whether the patient has ulcerative colitis or Crohn's disease. So you call it IBD-U or IBD unclassifiable. The simplest pathophysiology of this disease, obviously we're not going to detail about, is that there is a genetic predisposition, there is an aberrant immune response, and gut microbiome or environmental factors, predominantly the gut microbiome, has a major role to play. Why it is important for us to know? Because if aberrant immune response plays a major role, so obviously drugs which modify the immune responses are going to be very useful for treatment. If gut microbiome plays a major role, so again, agents which can manipulate the microbiome, gut microbiome, they also play a major role in treatment. Earlier, IBD was considered not to be a very common disease in this country. In fact, 2 to 3 decades back, Crohn's disease was considered to be rare. However, in last 2 3 decades, what we have seen that IBD disease burden seems to be pivoting to Asia, what we call as a great shift east. In fact, like Western countries, which are supposed to be having the highest burden of IBD, and now it seems that obviously India and China, by virtue of their large populations, actually have amongst the highest burden and equal burden, I would say, as USA, or in fact, when you take whole of Europe together, you would be having around 1.5 to 2 million cases of IBD in the country today. But the problem is that if you want to make a definitive diagnosis of ulcerative colitis, there is nothing like a gold standard. That does not exist. That compounds the problem. If you want to make a diagnosis of, let's say, enteric fever, you have blood culture. You want to make a diagnosis of, let's say, malaria, you have a definitive test. But for inflammatory bowel disease, there is no single test which can make a diagnosis. You make a diagnosis of ulcerative colitis based on combination of clinical features, lab features, imaging if required, endoscopic features, and histopathology. And if it is the problem arises, if the patient comes for the first time with a very short history, if the patient has a chronic history, then that makes the job very simple. The moment the patient gives you a history of, okay, 6 months history of diarrhea, in between the symptoms are going up and down, sometimes lot of symptoms, sometimes less symptoms, chronic diarrhea, blood loss, okay, you're dealing with a chronic condition. Suppose a case of ulcerative colitis presents to you for the first time with just a very short history, then there is a lot of confusion. And that is why I said that at times infective cause needs to be excluded, and we'll talk about it in detail further. So essentially, when you're diagnosing ulcerative colitis, as I said, no gold standard. It's a combination of clinical features, lab features, and what other investigations we may be doing. Amongst the clinical features, it is large bowel diarrhea. So obviously, chronic diarrhea with blood, rectal symptoms, urgency, tenesmus, passage of mucus. Abdominal pain is not so common in ulcerative colitis because ulcerative colitis is a mucosal disease. Abdominal pain is much more common in patients with Crohn's disease. Crohn's disease is a transmural disease, so there you would have a lot of abdominal pain. When ulcerative colitis is very severe, then you may get systemic features of anemia, fever, tachycardia, or signs of malnutrition also subsequently. Urgency, tenesmus, and all are features of rectal inflammation because there's loss of compliance. So there's a frequent desire to defecate with small amount of stool in the rectum, whereas anemia, fever, tachycardia are signs of severe disease. And if you want to investigate, there's nothing specific when it comes to lab investigations. You may find anemia, you may find iron deficiency anemia, but one interesting thing is that thrombocytosis is generally present. In patients with ulcerative colitis or Crohn's disease activity, you'll find that the platelet counts are high because they are acute phase reactants. ESR is high, CRP levels would be high, albumin levels would be low, particularly if they are severe cases. Since it is large bowel diarrhea, obviously the next immediate investigation, the moment you get history of chronic diarrhea, you get history of blood loss, is to go ahead and you have localized it to, okay, the pathology lies somewhere in the large bowel, then the first investigation of choice in such a setting should be a sigmoidoscopy or a colonoscopy. And a colonoscopy would easily help you to make a diagnosis of ulcerative colitis. How does it help you? Like in the top panel, you have a normal colon which shows normal vascular pattern. You see all the vasculature and all beautifully, acutely bifurcating, whereas subsequently once ulcerative colitis develops, there may be loss of vascular pattern, there would be superficial ulcers, there would be confluent loss of vascular pattern, and the ulcers may subsequently become from superficial, they may be deep, and they may bleeding and all. And while you're doing colonoscopy, it is very important to take biopsies if you want to subsequently fulfill all the components of your diagnosis. As I told you, diagnosis is based on compatible clinical features, compatible lab features, compatible colonoscopic findings, and compatible histological features. So what will be the compatible histological features? Most important thing is abnormal crypt branching or loss of crypt architecture. The crypt architecture will not be maintained. There may be ulceration, but that is non-specific. It is the aberrant crypt branching or crypt architecture destruction, which is very specific for a chronic inflammatory disease like ulcerative colitis. Besides that, you may find cryptitis and crypt abscesses. You may also find goblet cell depletion, and you may find some chronic changes like diffuse basal cell plasmacytosis or Paneth cell metaplasia. So essentially, histology, the moment on histology we get crypt architecture distortion, or if you can get Paneth cell metaplasia, diffuse basal plasmacytosis or goblet cell depletion, then okay, then you know that gradually that everything is falling into place. It's like four pieces of a puzzle. They all fit in. So you know, okay, you're clearly not dealing with a chronic inflammatory condition of the large bowel, where colonoscopy shows that there are confluent changes, loss of vascular pattern, ulceration, and it is involving only the colon, not involving the small bowel at all. You take a biopsy, and biopsy confirms features of chronicity in the form of crypt architecture destruction and basal plasmacytosis. So it's possibly a case of ulcerative colitis. Is there any role of imaging? Should you do a CT in such cases? Well, CT is required in a case of Crohn's disease because Crohn's disease can involve any part of the gut from mouth to anal canal. Crohn's disease can be inflammatory, Crohn's disease can be stricturing, Crohn's disease can be fistulizing. It's a transmural disease. So Crohn's disease can, one-third of the case of Crohn's disease involve the terminal ileum, one-third involve the large bowel, and one-third involve the ileocolonic area. So as a result, you need to, if you want to see the extent of the changes, you need a CT enterography or a MR enterography in a case of Crohn's disease. Whereas in a case of ulcerative colitis, it's a transmural disease. It only involves the colon. So you do not need imaging in majority of the cases, unless until the patient is very sick or you are suspecting perforation. If the patient is, let's say, comes with very acute colitis, there's tenderness in the abdomen, go in for abdominal X-ray. Abdominal X-ray will rule out a perforation or document a perforation. Apart from that, what you may find is transverse colon, which is dilated 6 centimeters or more, which is known as toxic megacolon. Or if you have any diagnostic confusion with Crohn's disease in some cases, there you may go ahead with CT scan. Otherwise, CT scan is generally not required in a case of ulcerative colitis. Just with the help of symptoms, basic lab investigations, colonoscopy, or even if colonoscopy is not possible in the first instance, sigmoidoscopy plus biopsy, they help you to make the diagnosis. Often it is seen that such patients also undergo serological tests like ASCA and ANCA. ASCA and ANCA is anti-Saccharomyces cerevisiae antibody and anti-nuclear cytoplasmic antigen. So they are not useful. They are not helpful in making a diagnosis of IBD. They're also not very useful in differentiating Crohn's colitis from ulcerative colitis. So in general, ASCA and ANCA should routinely not be done either to make a diagnosis of ulcerative colitis or to prognosticate that disease. There's a very important marker which has come up, which is a very useful marker, which very easy to do and a very high diagnostic accuracy. It's a little expensive at the moment. The test ranges from, I think, 1,200 rupees to 3,000 rupees, depending from place to place. But yes, at the same time, it's a very useful test. This is known as a fecal calprotectin test or a stool test where you measure the calprotectin levels out there. What is calprotectin? Calprotectin is a cytoplasmic protein which is found in the neutrophils. So obviously, whenever there is any kind of inflammation, whether acute or chronic, the neutrophils would migrate, come to the lumen, they would get lysed. Once they get lysed, calprotectin is released. The released calprotectin can be measured in the feces. So fecal calprotectin is not a test which is specific for inflammatory bowel disease, but it is a very good test which is very specific for inflammation because of any cause. So if you are having difficulty in differentiating irritable bowel syndrome from inflammatory bowel disease, irritable bowel syndrome from ulcerative colitis or Crohn's disease, then you can do fecal calprotectin, and fecal calprotectin is raised, then you know that you're dealing with a chronic inflammatory disorder and you're not dealing with irritable bowel syndrome. Secondly, fecal calprotectin has also been found in, particularly in cases of IBD, to correlate with mucosal healing. When I say mucosal healing, it means endoscopic healing. It means the healing of ulcers which are present on the mucosa. If you look at this graph, these are values of fecal calprotectin. So whenever there is activity, you will find high levels of fecal calprotectin because obviously a lot of neutrophils, there's inflammation, neutrophils are attracted to the site of inflammation, they get lysed, the neutrophils get excluded in the lumen, they're lysed. So calprotectin is released and you measure the calprotectin and find it very high. When the patient is treated, as a result, the calprotectin levels start falling down, and when the disease like ulcerative colitis goes into remission, the calprotectin values would be normal or somewhere less than 100 microgram. So the moment a patient has a relapse, the calprotectin levels would go about 150 or 250. The values may differ a little bit depending upon the kit being used, and then you know that the patient is having a relapse. So it's a very easy way, non-invasive way by which you can monitor the patient and you can know what is the level of activity. So this is certainly a very useful test. Now, we have been talking till now of a 25-year-old lady who had chronic diarrhea and blood loss. Suppose this was a 25-year-old lady who had diarrhea for only 2 weeks. And that is the time she presented to you, along with blood and stools, along with urgency and tenesmus, all suggesting that, okay, this is acute diarrhea, but nevertheless large bowel diarrhea. The rectal symptoms are there, blood in the stools is there. So how will you make a diagnosis out there? This would be one of the common presentations of what is bacillary dysentery. It could be a common presentation of amoebic colitis. How will you decide whether the patient has amoebic colitis, the patient has bacillary dysentery, or the patient has this is the first episode of ulcerative colitis? The treatment, obviously, for ulcerative colitis would be different for the treatment of a patient with acute self-limiting colitis because of bacterial causes or parasitic causes. So, in such cases, often what is done is that routinely, obviously, you straight away do not do a sigmoidoscopy. Such patients you always treat first with a course of antibiotics, which may be ofloxacin, metronidazole, satronidazole, and tenodazole along with ciprofloxacin, and watch for the response. If the patient does not have a response, that is the time the patient continues to have blood loss with large bowel diarrhea. That is the time the patient should be planned for an unprepared sigmoidoscopy so as to see whether there are any mucosal changes in the rectum and sigmoid. Suppose you find mucosal changes in the rectum and sigmoid, like loss of vascular pattern or few ulcerations. Is it again diagnostic of ulcerative colitis? No, it is not diagnostic still because one component is missing. There is no chronic diarrhea. Right? You have to have some element of chronicity. And moreover, in bacillary dysentery or amoebic colitis also, you may have similar kind of features when you do a sigmoidoscopy. So what do? You always take a biopsy. In biopsy, if you find crypt architecture destruction or if you find basal plasmacytosis, then that helps you in pinpointing a diagnosis of ulcerative colitis. In fact, basal plasmacytosis is the first to appear. Focal or diffuse basal plasmacytosis is the earliest feature. It can come up in around 30 to 40% of patients within 2 weeks after the first symptom presentation. Crypt architectural destruction takes around 2, 3, 4 weeks. The first would be basal plasmacytosis. Why is this knowledge important? Because then, in a way, if you're suspecting something like that, you can ask your pathologist, okay, kindly look for these changes. Are they there or not? Is basal plasmacytosis present? Is crypt architecture destruction present or not? If that is present, then you know that you need not keep on repeating courses and courses of antibiotics. It is time that you made a definitive diagnosis of ulcerative colitis, even if the patient had just 2 to 3 weeks history of diarrhea, because the colonoscopic changes are consistent, the histology is very consistent. So in general, the algorithm would be first episode of diarrhea, just 2 weeks history. When you're confused, give a course of antibiotics, do a sigmoidoscopy, take a biopsy, don't find any changes, repeat. Then in that case, repeat. You can also repeat a sigmoidoscopy after 2 to 3 weeks. But if you find changes which are very suggestive on histology, it is time to straight away go on to make a positive diagnosis of ulcerative colitis and treat them with either steroids or 5-aminosalicylic acids depending upon the severity of the disease. So essentially, follow up with a course of antibiotics and repeat sigmoidoscopy and biopsy is the key in such cases. So coming back to our case, we have a 24-year-old lady with diarrhea for 3 months, blood and stools, rectal symptoms, tenesmus. So simply with clinical features, basic lab investigations to check for anemia, thrombocytosis, and all, and sigmoidoscopy and biopsy, we make a positive diagnosis of ulcerative colitis. Differentiate the biggest differential out here is generally acute self-limiting colitis. Or if a patient is elderly, let's say for the 65-year-old lady, then it would have been colorectal cancer. Then again, a colonoscopy would have helped you straight away in differentiating from that kind of entity. And so you make a positive diagnosis of ulcerative colitis. So the two differentials essentially remain acute self-limiting colitis, or which is bacterial or amoebic in origin, or colorectal cancer, depending upon the age, in such a setting where there is bloody diarrhea. For Crohn's disease, the differential remains intestinal tuberculosis. That is a different set of discussion altogether. Here we are dealing with blood and stools. Blood and stools is a predominant manifestation of ulcerative colitis and not Crohn's disease or tuberculosis. The next, after you have made a diagnosis of ulcerative colitis, second is to look for extraintestinal manifestations, because IBD as such is associated with a lot of extraintestinal manifestations, which may be in the form of diarrhea, which may be in the not diarrhea, peripheral arthralgias, central arthralgias, uveitis, primary sclerosing cholangitis, pyoderma gangrenosum, and all. Here come two issues which become very important once we have reached till this point. If you want to treat further, you need two bits of information. Both these two important bits of information are what is the disease activity and what is the disease location, because these are two cardinal points which are going to help you in managing the patient. So when you're going to manage the patient, first is you have made the diagnosis. Once you have made the diagnosis, then I would require two data points more. These 2 points are disease activity and disease location. When we talk about disease location, it means, okay, the disease extent in a way, right? So there is a Montreal classification for that, regardless of whether it's a classification or not. With the help of colonoscopy, you can map out the extent of the disease, because colonoscopy, as we all know, can go till terminal ileum, and ulcerative colitis is restricted essentially to large bowel, to colon. It's only in 5 to 7% of cases there may be little bit involvement of terminal ileum, which is known as backwash ileitis. Otherwise, essentially and mandatorily, I would say it is a colonic disease. So E1 or the proctitis. So proctitis is when you find that the disease is limited to 15 centimeters from the anal verge. When disease is limited up to the splenic flexure, it is known as left-sided colitis or E2. When the disease extends beyond the splenic flexure, it may be called as extensive colitis or pancolitis in general if it is extending right up to the cecum. This is the maximal macroscopic extended colonoscopy. And why it is important, we'll see further, because obviously the treatment and the natural behavior of the disease, which is limited to proctitis, may be different from disease which is limited to left colitis or disease which is involving the whole of colon. So this is knowing the disease location. Second is knowing the disease severity. Disease severity is based on looking at clinical features like stool frequency, presence or absence of rectal bleeding, doing a sigmoidoscopy and finding whether how severe the activity is on sigmoidoscopy in terms of ulcers are superficial or deep, there is friability or not, and physician's global assessment. So there are many, many scores available. One of the common score which is used is Mayo score, whereby 0, 1, 2, 3, whereby BO3 and all suggesting that it is a severe disease, whereas 0 is a normal disease. So why it is important is it gives you a sense of objectivity when you're going to follow up these cases, because remember, these cases are going to be there with you for life. These are lifelong diseases. These are chronic debilitating illnesses starting at the prime of the youth when people are in their 20s or 30s, and subsequently, unfortunately, the patients have this disease all along. So you need some very objective parameters if you want to see, okay, last year what was the activity, then the patient was on this kind of therapy, now what is the activity and all. And secondly, if the patient is having mild activity, the treatment would be different from when patient is having severe activity. You obviously do not need to remember these scoring systems because they're easily available on apps and all nowadays. Another score which is still being used is True Love and Wit score. This is a very old score, came up around in 1960s, and very easy to remember this one. This divides the disease in mild disease versus a severe disease. The easy thing to remember is that it has two symptoms, two signs, and basically two investigations, which are sort of, I would say, basic investigations. Two symptoms are number of stools per day and the blood in stools per day. Two signs are pulse and temperature. Two bedside investigations are hemoglobin or ESR. So all it does is if you want to differentiate a severe disease from a mild disease, if a patient has more than 6 bloody stools per day and either tachycardia or raised temperature or anemia or raised ESR, then you know that you're dealing with a case of acute severe ulcerative colitis. That is the best, I would say, application of this score. The moment you diagnose a patient as having acute severe ulcerative colitis, then you know that this patient requires hospitalization, because acute severe ulcerative colitis means that the patient has to be treated with intravenous therapy. So if you find the patient has more than 6 stools per day, the stools are all bloody, along with that, the patient may have either tachycardia or fever or a low hemoglobin or raised ESR, then the patient would be classified as having acute severe ulcerative colitis. So till now, what we have discussed is that while making a diagnosis, history is important to look at for chronicity of diarrhea, organicity of diarrhea, large bowel diarrhea or small bowel diarrhea, presence and or absence of extraintestinal manifestations. A colonoscopy is essential for diagnosis. A colonoscopy or sigmoidoscopy is initially, and then thereafter you can do a colonoscopy to know the extent of the disease and also to know the severity of the disease. Histology or biopsies taken during colonoscopy are very important, because if you can document crypt architecture destruction or basal plasmacytosis, that would confirm the diagnosis. And then you need, apart from disease location, you need another point, which is disease activity, which you can measure very easily with the help of True Love and Wits or with the help of Mayo score. And once you're armed with all these facts, you are ready to treat. So while you are ready to treat, I think there are one or two points which you should keep in mind, which are important, I would say practical points. That is knowing the behavior of the disease. This is a mucosal disease. The basic difference between ulcerative colitis and Crohn's disease is ulcerative colitis is a mucosal disease. It does not become a transmural disease. So ulcerative colitis moves in only one direction. That is, it is a mucosal disease, but it can increase in length. In other words, if it is proctitis, 10 to 20% of cases may subsequently, you'll see 2-3 years later, they're not improving. Then you do a colonoscopy, you find that initially it was proctitis, now the patient has pancolitis. Similarly, the patient of left colitis, they may go on to develop pancolitis. Similarly, there may be a regression also. Some patients of pancolitis may go on to regress and become left side colitis. Whereas in Crohn's disease, what we find is that it's a transmural disease. Crohn's disease, the behavior changes. The behavior, when we say changes, is that initially it would be mucosal, inflammatory. Then subsequently it would become totally transmural, and as a result it would lead on to structuring disease, and thereafter it may go across the wall, and as a result there would be fistula, or there may be abscesses, what is known as a fistulizing disease. So that is a basic difference in behavior between ulcerative colitis and Crohn's disease, besides essentially that ulcerative colitis involves only the colon, and Crohn's disease can involve any part of the gut from mouth to inner canal. So this behavior of disease progression and regression is important. Second thing is, these graphs show that how over the years various disease patterns you may see. Some patients, there may be an initial severe disease, initial severe symptoms, and thereafter the symptoms just settle down over the years. In some cases, much less in number, you may see that patients are generally having very low disease activity, and suddenly the activity shoots up and plateaus, high activity. But half of the cases, what you would see is that either there would be chronic intermittent symptoms, or you would have chronic continuous symptoms. These are the patients you generally come to the hospital much often, and these are patients you often deal with. Whereas these are the patients whom you would see once or twice, and then they would be self-treating themselves, or they would be coming to you even if they have been seeing them once every 3 years or once every 4 years. So it is a chronic continuous or chronic intermittent symptoms. Those are the ones which have frequent remissions and frequent relapses. As a result, they require a lot of fluctuations in therapy. And so come up two terms. One is steroid dependent and steroid refractory. When we say steroid dependent diseases, that when you put these patients on steroids to decrease the immune responses, in 4 weeks, 16 weeks time or 4 months, it is not possible to taper them off. The moment you start decreasing them, the steroids, they reach till, let's say, around 10 milligram, then there's a relapse of activity. Or you stop the steroids, within 3 months, there would be a relapse of activity. Steroid refractory is, even though you're giving them steroids for 3 to 4 weeks, still there is no active response. So all it tells you that you need to move on to the next line of therapy. So when we come to management, the principles of management, disease severity, you need to know, because that will decide how you're going to treat. Disease location, you need to know, because that will decide how you're going to treat. You have to induce remission, maintain remission. In other words, for a majority of them, 95% of them, I would say it's a lifelong therapy. And if you do not maintain remission, only induce remission, they're going to come back in 1 year time or 2 years time with a severe relapse, which would be difficult to manage. The therapies which are used are, as we talked about the pathogenesis, we said there's a genetic predisposition. So obviously genes cannot be changed, and it's not a monogenic disorder. So overall bone marrow transplantation would not be helpful. Second is aberrant immune response occurs. So obviously if you change the immune responses, that will help you to treat. So among the therapies which have been used to change the immune responses, so it's a step up ladder pattern in terms of treatment. There's a sequential therapy. If the patient has a mild disease, you start with aminosalicylates, that is 5 aminosalicylates, or you may start with sulfasalazine. If the patient has an increase in disease activity, you move on to corticosteroids. Patient requires a lot of corticosteroids, you may require steroid-sparing agents like thiopurines, that is azathioprine or 6-mercaptopurine. Patient is still not responding, then you move on to what are known as biologics, anti-TNF monoclonal antibodies or cyclosporin, or at any point of time out here, surgery in form of colectomy can be done. So whatever we have discussed till now, if we apply it, so we know that we have to induce remission, thereafter we have to maintain remission. We have to see whether ulcerative colitis is what is the activity of the disease. So activity can be severe or activity can be mild to moderate, or the patient can be in remission. Suppose we have a patient of mild to moderate ulcerative colitis. What would you do next? You all would like to know what is the disease extent. Proctitis or left-sided colitis or pancolitis. They are grouped in one group only because they behave similarly. If it is proctitis, that means it's a local disease. If you give tablets, oral tablets, are not going to work so well. You need to give local topical therapy, which is in the form of 5 ASA suppositories, around 1 gram per day. If the patient responds very well, if the patient is not responding, then you may either add the steroid enemas, or you may add also oral 5-ASAs. In case of left-sided ulcerative colitis or pancolitis, you add oral 5-ASAs. Oral 5-ASAs or sulfasalazine can be given. Oral 5-ASA generally given around 2.4 to 4.8 grams per day, or sulfasalazine 3 grams per day can be given. If the patient responds fine, if the patient does not respond, then as we discussed in the previous graph, you move up to the next step, that is a steroid. So steroids are given, and thereafter the patient does not respond to oral steroids, and IV steroids can be given. However, if the patient has severe disease, then you do not start with 5 years. You straight away start with steroids, oral steroids, irrespective of the disease extent, whether proctitis or left colitis. And thereafter, once you have given steroids, if the patient is responding to steroids, then you can taper off and maintain on 5 ASA. If the patient requires multiple courses of steroid, you may put the patient on azathioprine and all. Acute severe ulcerative colitis, as we discussed, is a medical emergency in a way. When you apply True-Love and Witts criteria, you find more than 6 bloody stools per day. Along with that, there may be tachycardia, there may be fever, along with the ESR raise or anemia, any one of these 4 features. Then you label that patient as having acute severe ulcerative colitis. There you would straight away start with intravenous steroids, give intravenous steroids for 5 days, and then you see the response on day 5. If the patient is responding, then you taper up the steroids and add azathioprine. However, if the patient is not responding, then you have 3 choices: surgery or TNF monoclonal antibodies in the form of infliximab or cyclosporin. Infliximab and cyclosporin are equally effective in such a setting. However, surgery can also be tried. Then the next step is maintenance of remission. We talked about induction till now. The patient is responding in different settings. How are you going to maintain it? If the patient just remission was induced with the help of 5 ASA, there has been no steroid requirement. You can maintain the patient on 5 ASA for next many years. The patient can continue to take 5 ASAs, and obviously when there's a relapse, then according to the relapse, according to the disease activity, if the patient requires steroids, you may give it. Otherwise, 5 ASAs enough. If the patient had occasional just one steroid course, then also you can maintain the patient on 5 ASA. However, if the patient was steroid dependent, we talked about that you try to taper off steroids, the patient has a relapse. You stop steroids, within 3 months, the patient has a relapse. The patient is, let's say, taking more than 2 steroid courses a year. That is steroid dependency. There you need to put the patient on what are known as immunomodulators or what are known as thiopurines, that is azathioprine or 6-mercaptopurine. So you may give 5 ASA plus azathioprine. Patient does not respond, then you move on to TNF monoclonal antibodies, which are the biological therapy, or the patient may go in for surgery. Similarly, a patient of acute severe ulcerative colitis, for maintaining remission, you need 5 ASA plus immunomodulators. Surgery is curative in ulcerative colitis. We'll talk again later subsequently about it. But still, surgery is something very challenging, I would say, in ulcerative colitis. The indications for surgery in ulcerative colitis remain: one is the regular indications. Okay, if there's a perforation, massive bleeding, or toxic megacolon, that is the X-ray I showed you, more than 6 centimeters transverse colon dilated, acute severe ulcerative colitis with systemic features. Or if the ulcerative colitis is a pre-malignant condition, after 10 years, the risk of colorectal cancer is there, which by a third decade of disease, or 20 or 30 years after the disease, is to the tune of 10 to 20%. So the patient has a malignancy. Or surgery is done in ulcerative colitis in patients who have steroid refractory acute severe ulcerative colitis. You started the patient on IV steroids, given for 5 days, there is no response. So now you have a choice to give either infliximab or cyclosporin, but the patient cannot afford infliximab. That's an expensive therapy. Then the patient can be taken up for surgery. Or if the patient has a steroid dependent disease, he's marinating in steroids, he's continuously on 20 to 30 milligram of oral prednisolone, he is developing steroid toxicity and all, he's not responding to azathioprine, in such cases, surgery is definitely an indication. Now I'll come to certain, what I would say, a little bit tricky situations, or what I would say, not tricky situations, I would say call them tricks of the trade in a way, that where are the places where certain errors can be done, and that is, these are lifelong diseases. So if the patient is coming with frequent relapses, it's very important to check for adherence, whether the patient is able to afford the medication. If able to afford the medication, is he taking all the medicines? It's not easy every day to take medicines 2 or 3 times a day. Secondly, ulcerative colitis, the maximum disease inflammation would be in the rectum. So whether you're giving oral therapy or not, if the patient has a relapse, some patients respond dramatically to enemas and suppositories. So even if the patient has span colitis or left colitis, it is necessary to give enemas and suppositories if the patient is having a relapse. Third is dose optimization. A patient is on 2.4 grams of 5-aminosalicylic acid, not doing well, then obviously if you optimize the dose, bring it up to 3.6 gram or at times to 4.8 grams, the patient would start doing well. Patient is on azathioprine but is only on 50 milligrams. The correct dose of azathioprine is 2 milligrams per kg. So obviously for a 60 kg person, it would be somewhere around 120-25 milligrams. So if you optimize the dose, then the chances of relapse would be less. Secondly, as I talked to you about, okay, topical therapy, 5-ASA, then remember that when you start 5-ASA, it takes 2 to 4 weeks for ACT, and azathioprine, it requires 3 months for action to manifest. It is not that you started azathioprine today and within 15 days there is no response, you feel that, okay, fine, now we can stop azathioprine. No, azathioprine takes 3 months to 6 months at times, but generally 90% of patients respond by 3 months. Another mistake which is often done is steroid tapering of too fast. Steroids are started, tapered off within 20 days, 1 month. That is not right for a chronic inflammatory disease like ulcerative colitis. Essentially, you require 3 months or 4 months of steroid tapering. You should taper off steroids. The more slowly you taper off the steroids, the lesser the chances of relapse would be there. Another issue is that every time when the patient comes to you, it does not mean that the patient comes to you with active symptoms, does not mean that those symptoms are because of ulcerative colitis. If there are things like superimposed infections. In severe ulcerative colitis, particularly patients who have been taking steroid courses, cytomegalovirus is often seen, and that changes the course of the disease at that stage. So you have to pick that up. Patients who are on steroids or who are on anti-TNF monoclonal antibodies, they are predisposed to tubercular infections. Steroids, we all know, anti-TNF monoclonal antibodies, because TNF is suppressed. The moment TNF is suppressed, as a result, interferon gamma gets suppressed. As a result, what happens is that tuberculosis reactivation takes place. In India, it has been seen that 10% of cases on anti-TNF therapy may go on to develop tuberculosis. If there's a long-standing chronic disease, it often happens a patient walks in who is on follow-up for 20 years, 30 years, doing well, and suddenly has a relapse. And the knee-jerk response is, okay, start steroids. But be very careful. Has the patient had a colonoscopy in last 5-10 years? Is it possible that the patient is developing now colorectal carcinoma? Then patients of ulcerative colitis at times may also have superimposed or in addition features of irritable bowel syndrome. So the patient may not be having any blood loss, just a little bit of disease activity. The moment you do a sigmoidoscopy or something, you'll find there's no mucosal activity at all. There are just some symptoms which can be treated like when you treat a case of IBS. So these are things which you have to keep in mind. For example, CMV would present with deep ulcers. You take a biopsy for CMV DNA real-time PCR. It should ideally be done whenever you have any case of severe relapse. And if the biopsy shows intracellular inclusions or a IHC immunohistochemistry is positive, then you need to treat the patient with IV ganciclovir and taper down the steroids. Another infection you can look for is Clostridium difficile infection. Although we do not find it so commonly, CMV, we have seen that it is very common. Clostridium difficile, obviously, in such a setting is also common. And here you do the basic test, what you do for C. diff. You may have a two-step approach, that is, do a more sensitive test of GDH, fecal glutamate dehydrogenase, and subsequently go on to do toxin A and B, and thereby make a diagnosis and treat. Then remember, whatever treatment you are giving, if you are giving suppositories, they are only going to act in the rectum. So in a way, that is good, because rectum is a maximum site of inflammation. But if you want to look at, also involves, see the sigmoid also gets treat it, then you would like to give foam enemas. If you give liquid enemas, they reach up to the splenic flexure, enemas which have a volume of 70 ml or 100 ml. Whereas oral tablets, generally would be more in the right colon, the transverse colon, or out here. So if a patient has proctosigmoiditis or something, if you're going to give oral tablets, always combine enema or suppository along with that, and it gives dramatic results. All 5 ASs are not the same. Sulfasalazine is released in the colon, right? Preparations which are available, like mesalamine preparations, which are the normal all the 5 ASA preparations which are available, most of them are released in the terminal ileum and the colon. Preparations like pentasa are released in the jejunum and they go on up to the colon. So, for example, a case of Crohn's disease which has small bowel involvement, sulfasalazine is not going to act. 5 ASA preparations which are pH sensitive, they are not going to act. Their pentasa is going to act. However, if you have ulcerative colitis, then any of these preparations can act, right? Then is the steroids. So we have budesonide, which is available in India today, is budesonide controlled release preparation. That has a high first pass metabolism, but remember, it can act only, it gets released somewhere in the distal ileum. So it will act in the, maybe you can say proximal or distal ileum, and subsequently to the right part of the colon. So if a patient has ulcerative colitis, and ulcerative colitis, as I told you, is rectum, involves the rectum and then involves proximally. So obviously budesonide CR is not going to act in a case of ulcerative colitis. Whereas oral steroids, they will be distributed all over the colon, so they would be active out here. Budesonide CR, which is available in India, would be useful if you have a case of Crohn's disease, which affects the terminal ileum, proximal ileum. There it would be useful because budesonide will get released only in this area, whereas ulcerative colitis predominantly involves the left side of the colon much more. Budesonide MMX is another preparation which has not been launched in India as yet. That is a preparation which is specific for ulcerative colitis. So, but remember that this preparation is at this moment not available in the country. Then, when we talk about azathioprine or 6-mercaptopurine, they act in the form of by forming 6-thioguanine nucleotides, and as a result, they cause apoptosis. And azathioprine is a very good drug. It's a very cheap drug. It is quite an effective drug. In azathioprine, the only problem with azathioprine is that when we talk about the dose being 2 to 2.5 milligrams per kg, it has major adverse events like leukopenia, thrombocytopenia, and all. And particularly leukopenia is the one which is very troublesome. That can occur in patients who have NUDT15 polymorphisms. Earlier, it was thought that TPMT polymorphism is very important, but it was seen that it is more important in Caucasians. In Asian Indians, it is NUDT15 which is important. So NUDT15 polymorphism, if available, should be done. However, it is expensive, may not be easily available. So the best way to start azathioprine therapy is a step-up approach. Start with 25 or 50 milligram and step up, increase the dose and monitor CBC or LFT, right? And finally, we have the biologicals. Dr. Sandeep, do you have some time or you want me to wrap up? Hello?
Sir, please go ahead, sir. Please go ahead.
Okay. So azathioprine, again, there are certain simple issues that when do you say no response? As I told you, minimum 3 months of therapy before you classify it as a failure. How do you optimize therapy? Increase the dose to 2.5 milligram per kg. Some patients develop hepatotoxicity, or the patient is not having a response, then you add allopurinol because that inhibits xanthine oxidase pathway, moves the whole metabolic pathway in such a way so that more of 6-TG is released. That causes the action, but thereby at that time decrease the dose of azathioprine to 25 to 50. How long can you give azathioprine if the patient is doing well? I think you can give it for many years. Essentially, people thought that you stop it at 4 years, and people thought you stop it at 7 years. No, it is not that. You can go beyond 10 years easily. There is a risk of NHL associated with azathioprine, but if you discuss with the patient, and the risk is actually 1 in 10,000 or so, so you can go on giving azathioprine. Second line drug, azathioprine is not effective. Methotrexate was used. However, methotrexate recent studies have shown that it is not very effective. Now, if the patient has been given steroids, obviously steroid dependent, we talked about a steroid refractory, then steroid dependent, you want to take the patient off steroids because obviously steroid toxicity would develop. So you had azathioprine. Now, azathioprine is beneficial in 60% of such cases. But suppose azathioprine, you have to take the patient off azathioprine because 30% of patients of azathioprine develop side effects. Or azathioprine is not effective in 20% of cases. Then what would you do? Then obviously another choice you have is biologics are available. That is essentially TNF is the main cytokine which is released. And in India we have infliximab, golimumab is also available, although that is approved more for rheumatological conditions, and adalimumab is available. These are TNF monoclonal antibodies. Besides that, another group of biologics has been available in India. That is, these are known as lymphocyte trafficking inhibitors. These are lymphocytes. They are going to the blood vessels. So, if they have to go to the site of inflammation, they have to go through the endothelial wall. So, when they have to go through the endothelial wall, they have to go and attach to receptors on the endothelial wall. So, suppose, and the receptors by which they attach are known as alpha 4 beta 7. So, if you have monoclonal antibodies which block alpha 4 beta 7, the lymphocytes will not be able to attach and will not be able to infiltrate into the tissue. So, as a result, inflammation will not happen. So, in other words, if this is the site of inflammation, lamina propria, this is the gut epithelium and the lamina propria, then macrophages out here release a lot of TNF. You want to block this TNF, you have infliximab or adalimumab. However, if you want lymphocytes from not reaching out here, so lymphocytes are in the blood vessels, so you can stop that. You can do that by lymphocyte traffic inhibitors or alpha 4 beta 7 antagonists, or what is known as vedolizumab, which has been launched in the country this year. And another very exciting thing which has happened in the meantime with this, I would say in last 1 month, is that there's another class of compounds. Those are known as oral small molecules, which are orally administered. Biological agents require IV or subcutaneous infusion. So these oral small molecules, they have no immunogenicity. They are not proteins, so antibodies are not formed against them. And that is tofacitinib. Tofacitinib essentially is what is known as a Janus kinase inhibitor. In other words, all the cytokines, they will come and attach to receptors on the walls of the lymphocytes, and as a result, when the cytokines get attached out here, they will trigger the whole pathway of inflammation. The pathway of inflammation is triggered by Janus kinase pathway, JAK pathway. So JAK1 receptor, JAK2 receptor, JAK3 receptor. Tofacitinib will block these receptors. When it blocks these receptors, as a result, this inflammation does not occur. So in other words, whereas infliximab was blocking only one receptor, TNF, vedolizumab was blocking only one receptor, alpha 4 beta 7. Tofacitinib can block multiple receptors, so it can block multiple cytokines. And the very interesting thing is that tofacitinib is it has come out in India in the generic form, or whatever you say, that it is defying the patent or whatever. So it is very, very reasonable. Where the cost for infliximab for 1 year would be somewhere around 3 lakhs, 3.5 lakhs, even when you use the biosimilars. Vedolizumab would also go to around 3 to 4 lakhs. Tofacitinib for 1 month, the cost would be somewhere around 4,000 rupees at best. And tofacitinib is as effective a drug as infliximab, adalimumab, or vedolizumab. So that is what I would say. What happened to hepatitis C, the way things happened with hepatitis C, in terms of sofosbuvir and all came up, and they were so reasonable in India as compared to Western country. The same kind of thing has happened in India with the launch of tofacitinib. Tofacitinib in USA is very, very expensive, whereas tofacitinib in India is as expensive as the 5-amino salicylic acid. And obviously it is as effective as infliximab. So this is, I would say, something which is very good, which has happened for the patients of IBD in the country. So which biological agent to use if you were to choose? And obviously, you have to remember that for acute severe ulcerative colitis, only infliximab will act. Adalimumab does not act so well. Vedolizumab has a very slow onset of action. Whereas if you want to use steroid-dependent induction or steroid-dependent maintenance, any such cases where you want to use biologics, then you can use any of these agents. But as I told you, that from last month, the tofacitinib has come up, and tofacitinib would be useful for induction of steroid dependency, for maintenance of steroid dependency. All these indications, the same place tofacitinib can be used. And when anti-TNF biologics do not work, or when anti-TNF biologics are unaffordable, then surgery remains a very good choice. Tofacitinib, I've told you, tacrolimus is there. Fecal microbial transplantation is being done at many centers. The results with randomized controlled trials are good, although it still remains in the realm of research in a way. And why is it that colectomy, despite being curative, remains an attractive choice, I would say, is because it's a three-step surgery. First, you remove the colon subtotal colectomy, then you make a pouch and you make a diverting ileostomy, and in the third step, you close the ileostomy. So as a result, the whole process takes around 1 year, 3 steps of surgery. And after that, also the stool frequency is 8 to 10 times per day, although the chances of malignancy are totally finished because the whole of colon has been taken off. Here, the patient is not on any immunosuppressive therapy, so the chance of infection because of immunosuppressive therapy has gone. Still, it does not remain a very attractive choice. So if I sum up all the algorithms, I would say if you decide that the patient, as I told you, the most important thing is while making the diagnosis is clinical features, lab, there's nothing much except thrombocytosis. Then you do a colonoscopy, look for the typical changes, take a biopsy. Biopsy, you find architecture disruption, crypt architecture disruption. You know, okay, you're dealing with ulcerative colitis. Okay. Then you want to know what is the disease extent, that you get to know with the help of colonoscopy, and the disease activity. It's a severe disease, mild disease, disease in remission. Because if it is acute severe ulcerative colitis, then patient requires admission. Acute severe ulcerative colitis, we are diagnosing very simply with Tuller-Witts criteria: two symptoms, no more than 6 stools with blood in them every day, two signs, that is, one of these two signs or two bedside investigations being abnormal: tachycardia, fever, low HB, high ESR or CRP. So patient has acute severe ulcerative colitis, admit. Give IV hydrocortisone 100 milligram every 6 hourly, or IV methylprednisolone 60 milligram per day. Assess the response at day 3, because that will tell you how the patient is subsequently going to do. If the patient has done well, then the patient can be switched over after 5 days of IV steroids to oral steroids. If the patient has not done well, then you know that this patient is going to, in terms of by day 3, if the patient has not done well, you know you have to go for steroid sparing therapies. The steroids is not, I'm going to say the colon medical rescue therapies or colectomies. When we talk about medical rescue therapies, there are two therapies essentially, either cyclosporin or infliximab. Cyclosporin you start generally at the dose of 2 milligram per kg in divided doses. Assess the response after 4 to 7 days. Patient is doing well, switch over to oral cyclosporin and add azathioprine. Patient is not doing well, go for colectomy, or you can think about switching over to infliximab. Other choices, if you have both these choices are equal. So your other choices: give the patient infliximab, assess the response in 4 to 7, give the second and third dose of infliximab also. You can give it at 0, 1 or 2 weeks in this setting, as compared to a general setting of 0, 2 and 6 weeks. That is a normal induction dosing of infliximab. And thereafter, if the patient is not responding, again go for surgery. Otherwise, this is what we talk about when it is severe ulcerative colitis. If the patient has mild to moderate ulcerative colitis, for proctitis, start with suppositories. Patient not responding, add to 5-ASA suppositories, add the topical steroids. Patient not responding, add oral 5-ASA. If the patient is not responding, then go on to oral steroids. In left or extensive colitis, you straight away start with oral 5-ASAs plus topical 5-ASAs. Watch for 3 to 4 weeks. Patient is not responding, go on to steroids. Patient is doing well on steroids, fine. If patient is not doing well on steroids or becomes steroid dependent, then you have to add azathioprine. Patient is still not responding, then you go on to give infliximab. With infliximab, patient is not responding, you can go on for surgery, or you can go on for tafositamab or vedolizumab, right? And subsequently, when the patient is in remission, patients of proctitis, you can continue to give them 5-ASAs only, and you can gradually decrease the dose of 5-ASA to thrice per weekly, and that should be sufficient for most patients. If the patient has a left side colitis or pancolitis, there you have to give lifelong oral 5-ASAs, because in a way these patients are predisposed to cancer, and so 5-ASAs are chemopreventive. If the patient who has been having a lot of steroids before he went into remission, there you have to maintain remission with azathioprine or 6-mercaptopurin. And the moment there is a relapse, obviously you go on to anti-TNF, you go on to surgery, or you go on to tofacitinib. In general, these are the various algorithms of managing. And finally, there's another concept which is coming up, that is treat to target. We're not going to talk about it. This is just to tell you that earlier we talked about improving symptoms, and we talked about steroid-free remission. Then the concept came up of deep remission. Deep remission essentially means clinical remission as well as endoscopic healing. And so nowadays, the target generally is not only clinical remission, but also to document endoscopic remission. And this is believed to would probably change the course of the disease. Thank you so much for your attention, please.
Thank you, Professor Vineet Ahuja, for a fantastic talk. We came to know a lot of things new. And I would like to see if there are any questions in the chat box. I mailed it to the host.
I would like to ask a question, sir. Actually, obviously, sir, tofacitinib is a very nice introduction. And actually, in a country like us, where we cannot offer biologics to everyone, so actually, Western data suggests that tofacitinib should be used when the patient fails to a biologic therapy. But considering the Indian perspective, where do you put this molecule actually? And what's your experience with this in UC?
So that's an excellent question, Sandeep, because in the sense that in Western countries, what is the position of tofacitinib? They say that when infliximab fails, then you can use tofacitinib, right? Or ustekinumab. That is the second line therapy. Now in India, if so, because it has never been it has never been put in a trial as a first line therapy. So that is why it has been put out there. Now in India, if a person cannot afford infliximab and tofacitinib, which is available, which is obviously a very cheap alternative, and we know tofacitinib is efficacious. Phase 3 trial available, data is available. Phase 4 trial data is available. So obviously, once we are conversant with which are the places, what are the side effects of tofacitinib, how you're going to screen a patient before putting on tofacitinib, we can easily put the patient on tofacitinib. That is where India can take the lead in terms of also generating data of tofacitinib as the first line therapy after steroid failure and show that it can be a cost effective alternative. The side effects of tofacitinib basically are that it can cause thromboembolic complications, it can cause hyperlipidemias, right? Or it can cause various kind of, at times it can cause cytopenias. Herpes zoster infection can be triggered off. So similarly, infliximab also causes tuberculosis and all those things. So that way there are certain side effects which are there. But if you monitor for those side effects, or if somebody has a history of prothrombotic defect, they will not give the patient tofacitinib and all. So if you are clear about it, that and you also need to screen for tuberculosis even in tofacitinib in terms of doing a CT chest the way you do for infliximab. So I think tofacitinib should be used. Obviously, we cannot use the Western recommendation because in Western countries, if they had this kind of pricing for tofacitinib, they would have also jumped onto it. So it's a golden opportunity for our country to use it that way. That is what I feel.
What message is only those not responding to steroids or those who are steroid refractory?
Those who are not responding to steroids, they're not responding to azathioprine or 6-mercaptopurine, right? And to be on the safer side, since you are in also like in terms of legally also, if the patient is not able to afford infliximab, you can obviously offer infliximab to such patient. If the patient cannot afford infliximab, then obviously tofacitinib is a wonderful drug for such.
So there is a step down approach. So any indication on day one we can start tofacitinib?
No, for a patient of mild, for which kind of patient?
No, suppose that there is step down and step up approach.
So step down and step up approaches are generally for Crohn's disease. In aggressive Crohn's disease, you may have like a perianal fistulizing Crohn's disease, enteric fistulizing Crohn's disease. You have a step down, top down approach. You start straight away with biologics, right? In ulcerative colitis, it's a step up approach. You start with 5-ASA, no response steroids, no steroid dependent azathioprine, refractory infliximab or surgery. So here tofacitinib comes in at that step after steroid and azathioprine. Again, to be on the safer side, I'd say, okay, offer infliximab. If the patient says no infliximab, you'll be very correct in offering tofacitinib. If the patient cannot afford infliximab, you'll be legally also 100% correct in offering tofacitinib.
Sir, I have a question actually. We have come across a lot of patients at the college. We have a lot of patients with ulcerative colitis who don't do well with, like, have a lot of surgical complications post azathioprine. So I would like to know your views. Like, how do we go about it? Do we stop? How far do we do the surgery?
You can, azathioprine in general, if you can stop 1 month before the surgery, that would be good. Because whenever the patient, and if you have the steroid dose, should be ideally below 20 milligram. And because what happens is that in settings like acute severe ulcerative colitis, where the patient is on heavy dose steroids and you have to at times take up the patient straight away for surgery, you do not have a choice. But
Yes.
in steroid dependent disease, you have a choice.
Yeah.
There,
Sorry.
if it is possible, then you should stop it at least a month before.
Yeah, in acute, definitely we do curtail the surgery, like we do the colectomy and leave the proctectomy for a later stage, maybe after 6 weeks.
And
But
secondly, the more you delay the surgery in terms of try to flog the colon, in terms of, okay, give more and more medical therapy, hoping that there would be a response, the poorer the surgical results would also.
yes, I absolutely.
Surgery is
Sorry.
timing, like it's like what happens is even the not only the physician, the gastroenterologist, in fact the gastroenterologist, the surgeons, the patients, all three of them in a way are little scared about the surgical part, what I've seen. Like it's not like lap cholecystectomy or any other abdominal surgery where the surgeon would rush in to take the patient.
Yes, absolutely. We agree with that, sir. I also agree with the idea that it should be more like deserving a surgery because it's obviously a large amount of an organ being removed. So,
And not a one-step surgery. It's even if you do laparoscopically, still it would be a two-step surgery at least. So because with one-step surgery, the pouches do not do well. So one-step surgery is not advisable. So at least a
yeah,
two-step surgery should be done, or at
yeah,
least.
at least a two-step surgery because most of the times that the patient, by the time the patients come to us, you open and you see the colon, it's so flabby and thin and friable, you're scared of doing a one-step procedure. So it's at least a pouch plus a ileostomy. And then maybe after some time, after 4 weeks, you close the ileostomy.
So does fecal care product, there is a misconception that fecal care product is an ideal marker to differentiate IBD versus tuberculosis.
No,
With,
no, no, no. It cannot differentiate because it is an inflammatory marker. So any case of inflammation, acute or chronic, would increase. Anywhere neutrophils are lysed, it would cause it. So no, it will help to differentiate IBS from IBD. It will help to differentiate IBD in remission from IBD in activity.
Dr. Joy, there are a few questions in the chat box. You can ask what are relevant
Yeah,
questions.
we just got a few. I was just waiting.
First is
Yeah.
acute pancreatitis with ASA.
Yes.
How common and can be restarted? Acute pancreatitis, yes, is in terms of that it's not a rare this thing, you do see it. I would say around 3 or 4%, 5% maybe, like cases of ASA, you see acute pancreatitis. Although obviously leukopenia or myelotoxicity is much more common, going up to the tune of 20-25%. So you should not restart. If you get acute pancreatitis with azathioprine, you should not restart. If you want to restart, there's a case series available where people used 6 MP. But again, in a way, little bit, you have to be careful. I would not be keen on starting 6 MP also if a patient has got acute pancreatitis. The only choice you have is that if 6 TG tablets are available. 6 TG tablets are often used in patients with acute lymphoid leukemia and all those things. So the whole pathway is azathioprine transforms into 6-mercaptopurine, which transforms into 6 TG. So if you have 6 TG tablets, 6 TG tablets, 6-thiaguanin tablets can be used in such a setting. But azathioprine, definitely not at all. 6-mercaptopurine case series is available. You want to try, you can, but I would not be keen on that at all.
There is another question from Dr. Smith Vagasia from Delhi. How frequently we need to do colonoscopy in IBD?
That's a good question because that is based, I think, on the last slide which I showed you, that there's a treat to target consensus built in. Until that, before that, if you look at it, the only time you needed to do a colonoscopy was when you made a diagnosis. In terms of diagnosis, you wanted to determine the complete extent. After that, if the patient is not doing well, then you will need to do a colonoscopy only for screening to rule out colorectal cancer. That is after 10 years of disease. Because in left colitis or pancolitis, after 10 years of disease, you have to do a screening colonoscopy to rule out colorectal cancer. Right? So that is the time. Or if the patient has relapse in between, there you can just do a sigmoidoscopy, that is sufficient. Now, with the treat to target strategy, which comes up, which says treat to target is that you're looking not only for clinical remission, you're also looking for endoscopic remission. So, either you monitor it with fecal calprotectin, or initially, after starting any treatment, 6 months after that, do a sigmoidoscopy or colonoscopy to demonstrate that there is the ulcers, the mucosal healing has occurred. Right? Let me add a caveat out here. Treat to target for ulcerative colitis still remains in the realms of research. It's a theoretical, it's still not moved into totally practical terms. So, if I'm not confused, the issue, colonoscopy to be done to determine extent during diagnosis, colonoscopy to be done or sigmoidoscopy done when the patient has a relapse and you want to rule out CMV infection, sigmoidoscopy to be done in any case of acute severe ulcerative colitis on the day first to document activity and to take biopsies for CMV. Colonoscopy to be done as a screening colonoscopy to rule out colorectal cancer after 10 years of disease duration. And then thereafter every 5 years. Besides that, there is a thing known as treat to target strategy, whereby people are advising that after starting any treatment, 6 months after that, do a sigmoidoscopy to document healing. But as I told you, that is still not very practical. Have I been able to clarify it? No. Still confusing.
Sir, I have one question, sir. Actually, sir, in a patient with acute severe colitis, in a step-up approach, if we start a patient on an IV steroids, and on a 4th or 5th day, if the patient has not responded, and we add on a biologics therapy. So actually, in a last patient I had, when I have added biologics, he initially responded for 2 days, and then he again started having a bleeding. So I've added a steroid, and he responded nicely. Now, I have added steroid also, and patient had already received an induction dose of adalimumab. Now, how to play with the steroid? How to taper
steroid, irrespective of whether you're going to add infliximab or not, biological therapy, you're going to switch over to 40 milligrams of oral prednisolone and taper it off over next 3 to 4 months. Right? That is steroid tapering.
Oh, is it, sir? We can, okay. So it should not be an early taper. Okay.
No. Secondly, you said adalimumab. Adalimumab will not be effective in acute severe ulcerative colitis. Vedolizumab will not be effective in acute severe ulcerative. In some case, you may treat and you may be successful, but in general, they will not. Infliximab will be effective in acute severe ulcerative colitis.
Okay.
And
it was actually... it was a Crohn's disease, actually, sir.
It was a case of
Crohn's with a severe bleeding. Okay. Yes.
I don't know to make of this question. Role of AZA metabolite investigations in blood, when to do?
So again, there are 6 TG and 6 MMP levels which are done, but they are available at only 1 or 2 centers in the country, 6 thiaguanine and 6 mercaptopurine metabolites. So it is when a patient on azathioprine, after 2-3 months, you want to check for their levels, and based on these levels, you will be able to decide whether enough azathioprine metabolites are there and what is correlated with the response in the patient. Patient is, let's say, not doing well, but the metabolite levels are very good. Then you know, obviously, the patient is refractory to azathioprine. Right? If the patient is not doing well, the metabolite levels are very low, then you know that the patient is underdosed for azathioprine. You increase the dose of azathioprine. So these are the situations in which you do azathioprine. And prior to starting azathioprine, you check for NUDT15 polymorphisms if you can do. Again, if it is not easily available to you, then you simply start azathioprine in low doses, 25 to 50 milligram, step up every 2 weeks after checking their CBC, that is their leukocyte levels. Leukopenia to nahi ho raha.
Sir, one question regarding the azathioprine. Actually, we do encounter many GI manifestations with the azathioprine, and some patients do not tolerate those manifestations. So, sir, how do you manage those things?
So 1/3 of patients on azathioprine have to stop azathioprine because of GI tolerance, because of leukopenias or pancreatitis or some other headaches or whatever, right? So when it comes to pancreatitis, we decided that, okay, you cannot do anything. You have to switch out of class, or if 6-thiaguanine tablets are available, you can give them that as well.
Okay.
In case of GI intolerance, you can easily switch over to 6-MP and see that whether it helps or not. And generally, it helps in a lot of cases in case of GI intolerance. GI intolerance ho gaya, headache ho gaya, usme.
Okay.
And in case of leukopenias, you can decrease the dose. If the patient does not have significant severe leukopenia, then in that case, what you can do is if the patient develops leukopenia dose of 100, then do not go above 50 milligram. Just monitor the patient well and do not go above 50 milligram.
Okay.
Rest. One question is not in sync with the topic in discussion.
Okay.
I think we're done with most of the questions. Sir.
Yes.
Right. Okay. Thank you.
So, any questions, Sandeep, Ram?
No, thank you, sir. It was a very excellent discussion, sir. Thank you.
So it was a fantastic pleasure. It was really a pleasure to have you on the talk.
Thank you.
We learned a lot of things. I hope
An honor, sir. Usually gastroenterologists listen to you throughout the world and country, but Ahmedabad physicians are really very, very lucky and fortunate to have you today.
No, you're such a dynamic lot, right? You're one of the most dynamic lot in the country. Like, I was checking out your website, jab abhi jo kar raha tha na, so I was looking there. You put up such nice videos and all out there, Yogesh. You put up excellent. A dynamic lot, and thank you so much.
Thank you, sir. Thank you, Sandeep. Thank you, Ram. Thank you, Dr. Joy. Good night, sir. Good night.
Good night.